Okay, so today we're going to talk about shock, bleeding and shock. If you do not take care of shock, you're going to end up with a dead patient because shock does kill. So, what's included in shock? We have the circulatory system, which blood goes in, blood goes out, right? Anywhere messed up with that, not going to work well. So, the main components we have are our heart, blood vessels, and our blood. Our arteries, they carry oxygen rich blood away from the heart. They're comprised of a thick muscular wall that enables dilation and constriction of the arteries themselves. Capillaries, they have the microscopic blood vessels. They're a vital exchange site. So without capillaries, we're not getting oxygen and nutrients passed through the capillary walls in exchange for carbon dioxide from cells. Okay. Veins carry oxygen depleted, blood rich in carbon dioxide back to the heart. So that's where it's coming back and it's going to get oxygenated, right? They contain one-way valves to prevent it to flow back into the bloodstream. What does our blood do? Well, it transports our gases to get gas exchange, provides our nutrition, excretion, protection, so our white blood cells, all of that stuff, temperature regulation, blood pressure regulation, all of that. Perfusion requires, we have to have perfusion to live, right? So adequate circulation of the blood throughout the body. If it's not adequate, then it's hypoperfusion. So inadequate perfusion of the body's tissues and organs. If we have hypoperfusion, then your blood pressure is going to be lower and we're going to start seeing some problems. So bleeding, let's talk about bleeding. Hemorrhage is severe bleeding. So not just, oh, I cut my finger, or if you're looking at your face is going to bleed way more than if I cut my finger, right? But is it hemorrhaging? Usually not. Hemorrhage is the major cause of shock in trauma, and there's external hemorrhage and internal hemorrhage. So external bleeding, bleeding you can see, right? We're going to start over here with capillaries. Capillaries, it's slow, it's even. Ow, I paper cutted myself, right? This one can take a little while to stop oozing and everything. Veins, so venous, steady flow, it's slow, and it's a dark red color. So that's where, you look and you're like, whoa, my blood's like almost purple. That's that venous blood. Now also, it's going to bleed worse if I cut it this way down the tissue than if I cut it this way across the tissue. So it's just going to make a big difference on how that is cut. Arteries, it is spurting, squirting, pulsating, ketchup coming out of a bottle when you open it, squirt, right? So that one, that's a life-threatening emergency, right? Venous bleeding can also be life-threatening depending on how much there is, but arterial, if it is spraying, it is not good. External occurs outside the body, right? Typically visible on surfaces of the skin. So how much am I going to bleed depends on my size, severity of the wound, size and pressure of the vessel, and the individual's ability to clot. If you don't have the ability to clot, so you're on clot busting medication, you're on Coumadin, anything to prevent a clot, maybe they have AFib, and you're looking at that going, whoa, they can't clot, right? So they could continue to bleed and bleed and bleed and bleed and bleed from such a small little cut. Then we can become shocky just from that. So massive hemorrhage is arterial bleeding, bright red, spurting with each heartbeat. It's oxygen rich, and it is the most difficult to control. You see this, and it is like we need to be fixing that yesterday. Venous bleeding, again, darker in color, less pressure required. to go ahead and take care of that. However, it can create immediately life-threatening hemorrhage. Capillary bleeding, usually not going to die from a paper cut, even though people think that. It's slow, it's oozing, it'll stop, all right? Bleeding can be accelerated by underlying conditions, prescription medications, we already talked about that a little bit. Hypothermia, so if I'm too cold, I can't clot, okay? That's a huge problem. So, use standard precautions. If it's wet and sticky and not yours, don't touch it. If it's squirting and spurting, we're going to need goggles, right? Goggles, gloves on every single patient encounter, no matter what. Ensure the patient's airway is open, because if they're not breathing, we have a problem, right? Control bleeding only after assessing and treating prior elements. So, beware of signs or symptoms of shock. If it's shock, we treat shock first because that's a life-threatening condition. If it is squirting and it is a massive hemorrhage, that's a life-threatening thing, so we would fix that right away. However, all these other little venous scrapes, capillary scrapes, we're not even going to worry about that until after we have fully evaluated our patient for every life-threatening event that could be happening. So to treat shock, remember, we're going to lay down, position them flat if possible, cover them with a blanket, preventing heat loss, high flow O2. Use direct pressure, elevation, a hemostatic agent, or a tourniquet to control bleeding. So how do I use direct pressure? Well, I put pressure directly on the injury with a gloved hand, and it says a gauze bandage. If you don't have that right away, gloved hand's going to be the best until someone brings you some gauze. You're going to have to hold the pressure firmly until the bleeding's controlled. If necessary, we just keep adding gauze and gauze and gauze. Don't take the gauze off, because it did start to clot. Now you're going to pull that clot off. Once the bleeding is controlled, put a bandage over the gauze that you were putting pressure on to place a pressure bandage. Okay. When controlled, we still need to check for distal pulses on that extremity to make sure that the dressing hasn't been applied too tightly. I don't want to make a tourniquet out of something that wasn't supposed to be tourniqueted. So kind of like if you put the Band-Aid on too tight, your finger starts to get red and throb. That's what we're trying to prevent. A pressure dressing, to make that, you can place several gauze pads on a wound and hold dressings in place with self-adhering roller bandage wrapped tightly over the dressing, and it creates enough pressure to control bleeding. So basically, when you go get your blood drawn and they're using the Coban over a piece of gauze or the cotton ball, that's what they're talking about here. Elevate. So what we're talking about is elevate the injured extremity above the level of heart while applying direct pressure. You're not going to see this used as frequently anymore, because if it's not stopping bleeding right away, we're going to go directly to tourniquet. Do not elevate if musculoskeletal injury, or if there's impaled objects, or you have spinal cord damage suspected, or spinal injury. Then we're going to leave them flat and do what we need to do. Hemostatic agents, they're designed to enhance direct pressure ability to control the bleeding. You're not going to see hemostatic agents used very often pre-hospitally, except for in the case of law enforcement, military, that kind of stuff. They work by applying a material designed to absorb liquid portion of blood and leave a larger formed elements to clot. It originated as powders, but it does not include dressings and gauze bandages. So manual pressure is always necessary. You'll see these in the field. So if you work military, or again, SWAT team has these, law enforcement, any of the tactical combat teams, they all have those. Tourniquet is if bleeding is uncontrollable by direct pressure. It says only use on extremities. Obviously, I'm not going to be putting this around somebody's throat. And we always apply between the wound and the heart. Okay? I like to see the tourniquet a minimum of 2 inches above the injury. We prefer to go below the joint that is above the injury if possible. If not, I'm doing what I need to do. As you can see here, it looks like it's bled through a pretty significant trauma bandage. So they went to a tourniquet. I like how they have gowns on. That's realistically not going to happen. Okay. So with that, if it was a squirting or spurting, I'm going to tell you most protocols out there are going to tell you right to go to tourniquet. Direct pressure, tourniquet it almost instantly. That's going to be your best option for saving the life. Again, you're going to follow manufacturer's instructions on how to use those tourniquets. However, once applied, we never remove them or loosen them. The goal is to stop the bleeding. If I loosen it, they can bleed again. If we loosen it, they can also cause any of that blood that's below the tourniquet, which is now becoming all gross and infected and can cause a lot of problems, to go back into the bloodstream. Attach notation to the patient alerting other providers that the tourniquet has been applied. 99% of the time we can see the tourniquet, okay? If I can't see the tourniquet, you have not adequately exposed your patient. You do want to note the time that the tourniquet had been placed, however. So to control external bleeding, we do a systematic approach, right? Begin with direct pressure. If not controlled, apply the tourniquet. If ineffective and the wound is on the trunk or the head, apply a hemostatic dressing or a bandage with direct pressure. You're probably going to be using bandage with direct pressure, depending on what your level is and where you end up. Other methods of bleeding control, so splinting. Stabilizing sharp ends of broken bones. Remember, we don't push broken bones back into a body ever, ever, never, all right? If they are sticking out, they stay sticking out. Inflatable air splints, though, those are easy, nice. Not everybody has those. Cold application. It says it minimizes swelling, constricts the blood vessels, and reduces pain. However, previously we did read, if you have hypothermia, you can cause more bleeding. So don't get them too cold. All right, and we always use the cool application in conjunction with other techniques. So we already have it splinted. So now we're going to go ahead and put a cold pack, not directly on the skin, but there on the broken area to help prevent swelling. So special situations. Head injury from increased intracranial pressure, not direct trauma to the ears or nose. Literally stopping bleeding only increases intracranial pressure, allowing drainage to flow freely using a gauze pad to collect it. Okay. Nosebleeds, one of the main things that people have on a daily basis, kids get them. First thing people want to do is tilt that head back, right? So the blood's not dripping everywhere. That's wrong, all right? Have the patient sit and lean forward, direct pressure to the fleshy portion of the nostrils. It's going to be held there for quite a while. Keep the patient calm and quiet. Don't let them lean back. You don't want them to be swallowing that blood. It's going to cause problems with them having even upset stomach, nausea, vomiting. What if it's a huge clot? Now that clot can go right down in, if they inhale that into their lungs, now we have a worse problem. Or they can choke on that clot. So that's why we want everything forward. If the patient becomes unconscious, you want to put them in the recovery position, left lateral, right? And be prepared to suction, okay? Again, reducing that aspiration risk. Internal bleeding. Bleeding I cannot see. Very difficult to go ahead and try to treat bleeding that you can't see. So where are we going to go with that? Hospital, right? Don't waste time on scene for any severe hemorrhaging or internal bleeding that you suspect. Get them, load them, and go, all right? It's damage to internal organs, and a large blood vessel can result in a loss of large quantity of blood in just a short amount of time. Blood loss frequently cannot be seen. However, Severe blood loss can result from injuries to extremities even. So if you're looking at a fractured femur, fractured pelvis, bilateral fractured femurs, you can have someone that can be shocky in a very short amount of time. Mechanisms of blunt trauma are usually what's going to cause your internal bleeding. So did they fall? Were they in a motor vehicle collision? Were they in a collision with an auto pedestrian, right? Were they the pedestrian in that collision? Were they involved in a blast injury? Maybe not even hit by anything, but just that blast wave, that first pressure wave can cause significant damage. Penetrating trauma can cause internal bleeding as well, so gunshot wounds, stab wounds, impaled objects. Signs of internal bleeding: injuries that you can see, bruising, swelling, or pain over vital organs. So if I'm looking at left upper quadrant, what's there? My spleen. My spleen can bleed a lot, okay? If you look at someone and they have abnormal bruising on the left upper quadrant of their abdomen or on their side there, it's going to be a good indication that they have internal bleeding. All right, if they're bleeding from the mouth, rectum, or vagina, and especially if the mouth bleeding is not, more so they're coughing up blood, right? Vaginal bleeding is again going to be more so if they know they're not on their period, you know they're not pregnant, anything like that. So, on patient assessment, I'm going to look at it. That bruising right there, that is definitely internal bleeding. Now, is that going to be, you know, that injury right there, is that going to kill me? Probably not, but I'm not a doctor, so I can't say that. However, if that was over the abdomen, I'm going to be way more concerned about my patient. What do I do with my patient? Well, ABCs, high quality ABCs, right? Are they breathing? Let's keep them breathing and then work on their circulation. Administer high concentration oxygen by non-rebreather. Control any external bleeding. Take steps to preserve body temperature, again, keep them warm, and provide prompt transport to appropriate medical facility. If you're at a critical access area where you're out in the middle of nowhere and you've only got a critical access hospital that's available, that's going to be the appropriate care so they can get stabilized there and flown out somewhere else. Do you have access to a helicopter where you can go ahead and get them coming to you? That's going to be the best patient care for your patient. So let's talk about hypoperfusion shock. Okay, this is from bleeding, right? Inadequate tissue perfusion. It also causes inadequate removal of waste products from the cells. So shock in itself, if you're looking at the true definition, inadequate tissue perfusion. So failure of any component of the circulatory system. Heart, it loses the ability to pump. Blood vessels, they dilate, making too large of a container to fill. So that's where, you know, you stand up, get blacked out, fall down, all right? And blood, you lose volume from bleeding. So pulse increases to maintain cardiac output. So my heart is meeting the oxygen demand, right? My respiratory rate is going to increase, all of that. My blood vessels constrict, causing pale, clammy skin. If they are cold, pale, diaphoretic, that's under your ABCs, under circulation. I'm looking at skin, color, temperature, moisture, all of that. If they say cold, pale, diaphoretic, they're in shock. So we need to treat for shock, okay? The blood is shunted away from GI tract, causing nausea, because the blood is shunting to the heart, brain, lungs, things that need to keep me alive. The decreasing blood pressure is a late sign of shock. So we're looking at if their blood pressure systolically is less than 90, they're probably in shock. And uncontrolled shock leads to death. Compensated shock. The body senses the decrease in perfusion and compensates for it. Increase in respiratory rate, increase in heart rate, okay? Decompensated shock begins when the body can no longer compensate. Hypovolemic shock results from a decreased volume of blood and plasma. It is called hemorrhagic shock if caused by uncontrolled bleeding. It can also be caused by burns or crush injuries, severe dehydration. If you're looking at a patient that's had a urinary tract infection for the last several days, has been untreated, they can be dehydrated, now they're in hypovolemic shock. Same principle. You have a patient that has pneumonia, really high fever, not being treated by a doctor, has decided that they just don't feel good, so they're not drinking enough. All of that, hypovolemic shock can ensue. Cardiogenic shock, seen in patients that are suffering a heart attack or a MI. It results in inadequate pumping of the blood by the heart, okay? 40% of the left ventricle needs to be infarcted before the heart can no longer work adequately. 40% of one ventricle, that's all that it takes. So your cardiogenic shock doesn't take a whole lot, right? The heart's electrical system may be in a malfunction as well, causing the heartbeat that's too slow, so bradycardia, too fast, tachycardia, or my irregular heartbeats. So you can be looking at your AFib, brand new AFib folks that have never had AFib before, that can be causing a problem. A flutter. So AFib, a flutter, again, atrial. So those are the atriums not working correctly. Neurogenic shock results from uncontrolled dilation of the blood vessels because of nerve paralysis. So there's not a lot of blood loss, but the vessels dilate too much. That's not seen that often in the field. However, if you had someone that had a spinal cord injury and they've been laying on the ground for quite a while before anybody found them, you might see this. Infants and children are their own breed, right? So they compensate so well until half their volume is depleted, and then they die, okay? So literally the potential for shock has to be recognized well before. So with pediatrics, we're looking for, is there a mechanism of injury that could potentially lead to one of the shocks? If the answer is yes, I'm going to treat them like they're probably going to go into shock. What do I do with patient assessment? Okay. Progression of the signs and symptoms. If you start with a patient that already has an altered mental status, we have a problem. All right. If they're pale, cold, and clammy, diaphoretic, right, super sweaty, problem. If they tell you they're going to vomit, they're probably going to vomit. That's a problem. Vital sign changes. This is really where that trending of your vital signs comes important. I need to have at least 2 to 3 sets of vitals on my patient to know if my vital signs are trending downward. These patients, if they have appeared shocky or anything like that, they get vital signs every 5 minutes, okay? That's my personal rule. Late signs of shock include thirst. Their pupils will remain dilated. It can sometimes be cyanotic around the lips and the nail beds. That's just because they're not perfusing well at all. Transporting is an intervention. Every single minute between the time of the injury and the patient getting to an OR is going to contribute to the fact that he may not make it, okay? If you have a patient that's in shock, I want 10 minutes on scene or less. A lot of times we're looking at a 10-minute scene time or less for any trauma patient. Prevent further heat loss and further blood loss, okay? We don't want them to not be able to coagulate their blood by being hypothermic. Again, we already talked about this, maintain an open airway, okay? High concentration O2 by non-rebreather mask if they are in shock. Control any external bleeding. If pelvic fracture is suspected, you need to stabilize that pelvis before you even move them. So when you're looking at pelvic fracture, if they have an unstable pelvis, use some kind of binding device, whether that be a pelvic sling, putting them on a backboard, anything that you need to do to maintain that stability, because your retroperitoneal space can hold up to 5 liters of blood. That's a lot, right? So making sure that we're not letting them bleed. Do not splint to death, okay? But splint any suspected bone or joint injuries. Again, I can splint en route if I need to. Preventing heat loss is utmost important. Transporting immediately. And speak calmly and reassuring your patient. Don't be like, oh my gosh, I think they're in shock, they're going to die. That's not how you want to do this, all right? The more calm you can be, the better it's going to be at making your patient calm. Almost all external bleeding can be controlled by direct pressure and elevation unless we're looking at a large area or a large artery, those kind of things, okay? Emergency care for internal bleeding is based on prevention and treatment of shock. Early signs of shock are often restlessness, anxiety, pale skin, rapid heart rate, and respirations. If shock's uncontrolled, your patient's going to die. Signs and symptoms may not be evident early in the call, so again, treating based on mechanism could be your life-saving critical thing. Maintain airway, high flow O2, control the bleeding, keep them warm. Transport early. Remember, the circulatory system is designed to ensure adequate perfusion of the body. The classification of hemorrhage is directly related to the type of vessel ruptured and the pressure within that vessel. Again, we already just talked about applying tourniquets, that kind of stuff. Internal bleeding is impossible to evaluate, so rapid transport. Shock develops if the heart fails, the blood volume is lost, or the blood vessels dilate, resulting in inadequate perfusion. Signs of shock reflect the body's attempt at compensating before we pass away. And the most significant treatment for shock patient is early recognition. What to consider. So if you're out in the middle of nowhere, what can I use for a tourniquet that will control bleeding but not damage tissue, right? We want something at least 1 to 2 inches wide when we're thinking about using a tourniquet. All right. Binding or twine is not going to be the best. When treating a patient with shock, what should I do at the scene? And what should I do en route to the hospital? Well, on scene, quick evaluation, rapid trauma assessment, head to toe, treat life threats, maintain their airway, right? And do everything else en route to the hospital to keep them alive that you possibly can. Is a patient with pale, cool skin, tachycardia, rapid heartbeat, shallow respirations, in shock or just under stress? I'm going to tell you, they're probably in shock, okay? Continuing assessment helps make that decision. Mechanism, nature of illness, all of that kind of stuff. Trending vital signs. And there you got it. That is your bleeding in shock.